Retinal venous pressure influences both perfusion pressure and transmural pressure in the retina and therefore can influence the course of diseases such as glaucoma or diabetic retinopathy. Endothelin and other vasoconstrictors constrict retinal veins in and around the optic nerve head, thereby increasing RVP. This endothelin effect depends on both the local endothelin concentration and the endothelin sensitivity. The sensitivity, which depends on the local density of endothelin type A receptors on smooth muscle cells, can be enhanced by various factors. These include arterial hypotension or increased homocysteine levels. Since Ocufolin forte reduces oxidative stress, increased NO, and lowers homocysteine values, we investigated its influence on RVP. The purpose of this study was to investigate the influence of a vitamin supplementation containing L-methylfolate called Ocufolin forte, 1 capsule a day for 3 months on retinal venous pressure and on homocysteine plasma levels in patients with glaucoma and all other vascular diseases. Our inclusion criteria were glaucoma and or ocular vascular disease. All patients came from Oudenburg. They had an ocular dynamic force 15 millimeters of mercury or above in any vein in or at the optic nerve head, which means a retinal venous pressure at least 15 millimeters of mercury higher than the IOP, and a serum homocysteine level above 12 micromole per liter. The exclusion criteria were start of other medications with potential impact on RVP during or shortly before the course of the study, like for instance calcium channel blockers, the inability to adhere to the follow-up schedule, or the inability to perform a proper RVP measurement. Pre-treatment, on the first visit, patients had baseline measurements, including IOP and RVP. A blood sample was then evaluated, including homocysteine level, and decision was made for inclusion or exclusion of the patient. On the second visit, baseline measurements were repeated, followed by introduction of Ocufolin forte supplementation on the next day. During treatment, IOP and RVP were measured after 6 weeks, and in some patients also after 1, 2, or 4 weeks, and after 3 months. After the last study visits, a blood collection for homocysteine control was performed if indicated on the basis of ocular findings. All examinations were done by the same ophthalmologist. Homocysteine was measured using a serum tube with storage below 4 degrees of Celsius and or a homocysteine detection tube with analysis by the lab of the patient's GP. IOP was measured with Corvis, and ocular dynamic force was measured with an ophthalmodynamometer according to Leu. RVP was calculated from ODF and IOP with the following equation: RVP equals ODF plus IOP. Statistical analysis was performed according to a linear mixed effect model. These are commonly used models for repeated measure data. The selection of the veins is an important matter. The venous pressure of several veins was measured in and around the optic nerve head, including the central vein, hemiveins, and quadrant veins wherever possible. If anatomic variations hindered measurements at predefined locations, the position was carefully described to allow the measurements to be taken always at the same place at all visits. Vessels with a lower ODF were first measured in order to avoid a pumping effect with false lower ODF in subsequent measurements. Within the same optic nerve head, Some vessels may not show visible pulsations during ophthalmodynamometry, and then a maximum ODF value applied was noted, but this value was excluded from analysis. We included 23 patients with a mean age of 70 years, and ocular diagnosis was glaucoma in 16 patients. Most of them had normal tension glaucoma or primary angle closure glaucoma. 2 of those cases with primary angle closure glaucoma developed a unilateral branch retinal vein occlusion shortly before entering the study. 3 patients were glaucoma suspect. Pigment dispersion was noted in 2 patients, one of whom had a chronic Irvine gas unilaterally, and 2 patients had unexplained visual field loss. Huge differences in ocular dynamic force may be noted in different hemivenes and within the same vein from the optic nerve head center compared to the outer optic nerve head border. In the course of the study, as ODF in the center of the optic nerve head fell to 0 in some eyes, additional measurements locations further away from the optic nerve head center were added, yielding quadrant vein measurements in more eyes. Exclusion of results after starting a rescue treatment was performed in one functionally monophthalmic patient with BRVO who continued worsening clinically in spite of treatment, and there a photocoagulation of the ischemic hemiretina was performed. And in 2 other patients, 3 visits were excluded because other treatments with RVP lowering effect could have interfered. These are the results. In this graph on the left, you can see the first measurements that were taken pre-treatment and the results that were taken during treatment. Last measurement was taken 3 months after institution of the treatment, and the numbers show that retinal venous pressure has dropped from a mean of 34 to a mean of almost 24 millimeters of mercury pre versus post treatment. IOP has been stable throughout the course of the study, and retinal venous pressure could thus be attributed only to the lowering of ocular dynamic force, which has dropped from 22 to 12. RVP with these tablets was statistically significantly lower than before treatment, and the significance was very high. We also evaluated homocysteine level as an inclusion criterion before start of treatment, and in a number of patients after treatment, when we found that ocular findings were suggestive to test this again, and found that homocysteine level with Ocufolin forte was statistically significantly lower than before treatment. This result was again highly significant. Ocufolin forte is a vitamin preparation containing L-methylfolate. This is the active, bioavailable form of folic acid. Glaucoma and other eye diseases are often associated with a high retinal venous pressure and high homocysteine level. We found that Ocufolin forte significantly reduces RVP and significantly reduces homocysteine serum levels. In some patients, retinal venous pressure remained high in at least one vein, or morphological signs of high retinal venous pressure were still present at the end of the study. The study was, however, not placebo-controlled, and we only included patients with a homocysteine serum level above 12 micromole per liter. The treatment was limited to 3 months, and the potential effect of concomitant treatments that were started before the first visit was not evaluated. There are a lot of open questions. To name a few, what is the target RVP that should be aimed for? If the pressure in the different venous branches is different, which pressure is relevant? How long do we need to treat to maximally reduce RVP and/or homocysteine level? What is the response to Ocufolin forte in patients with normal homocysteine levels? And how should we evaluate RVP in patients with BRVO, and how should we optimally treat them? Because this is a particularly difficult clinical feature to manage. In conclusion, Ocufolin forte caused a clinically relevant and statistically highly significant RVP drop in patients with serum homocysteine above 12 micromole per liter. It led to a clinically relevant and statistically significant homocysteine decrease. An RVP lowering effect could be observed already after 2 weeks in some cases, but in most cases only after 6 to 12 weeks. Ocufolin forte was well tolerated by all patients, and we did not notice any side effects. Thank you for your attention.